Welcome to Psych Incubator and our series Eminent Psychotherapists Revealed. Tonight we are doing something different, and we're really pleased to introduce this new learning experience. And tonight we're going to be doing a master class, and I am very pleased to have as our host and guide for this evening, Dr. Louis Graff, who graduated from Emory University and completed his medical school training at the University of Connecticut. He then completed residency training in adult psychiatry at the Institute of Living at Hartford Hospital. Dr. Graff was awarded the Cornelius Bollhauer Award, I'm not sure I'm pronouncing that right, during his fourth year of residency in recognition of his abilities in education and professional leadership. He works at Charlotte Hungerford Hospital as a psychiatrist since 2014 and currently serves as Associate Medical Director in charge of all outpatient adult and child behavioral health care services, and also leads the quality improvement for behavioral health department. He's got a vested interest in diversity, equity, inclusion, and he's on the steering committee for a subcommittee focused on provision of equitable services. So thank you so much for taking time. Dr. Graff is also on call tonight, so if he gets a call, it's an emergency at the hospital he has to take care of. This is what we do. So thank you, Dr. Graff, for being our host and guide tonight. So we're going to talk tonight about a topic that I think is essential for all mental health clinicians and psychotherapists, and that is the topic of preverbal trauma. And so let me get my slides going here. So this is the topic for tonight, working with preverbal trauma. And the reason I say the silent scream is because a number of years ago, I was invited to consider writing a book on preverbal trauma, and I was going to call it the silent scream. And the reason I was going to call it the silent scream is because what I was aware of in my clinical practice is that many of the patients that I saw that were coming in that were suffering from um, an assortment of clinical syndromes and presentations, such as chronic fatigue syndrome, fibromyalgia, sort of chronic depressive disorders. They were often people that were not able to benefit from kind of traditional kinds of first line therapeutic approaches. And the silent scream was a way to get at how a lot of these people I felt like were screaming in a silent way for help. A lot of them were utilizing medical practitioners, and sometimes driving them really, really mad because they felt like they couldn't help them. They would often elicit a lot of countertransference feelings in the practitioners, because when we feel like we can't help someone, we can start to get irritated. So this idea that the person is screaming silently is a way for us to, as we go through some of the points this evening, for how to understand, number one, preverbal trauma, what it is, and then how to work with it, how to listen with that third ear that Theodore Reich talked about, like listening with the third ear. What are we really dealing with in this situation? So what is preverbal trauma? So basically, just to keep this as simple as possible, they're traumatic experiences that are retained without narrative memory. That's sort of I think the best way to get it. So usually patients will come into our practices in our clinics, and they're in pain, they're hurting, and we'll say, well, where's it hurt and what's making it hurt? And they can say, well, these are the issues in my life where it hurts. And maybe they can even have a connection or a link back to their early experiences that kind of encoded them in the way they were encoded and created the operating system that they have that makes them process information in a certain way and develop certain symptom constellations or disturbances in a certain way. So one of the things about one of the heuristics that I think can be helpful in pre-verbal and just determining whether you think someone that you're beginning to work with or are working with has pre-verbal trauma is one thing that I do is when someone comes in, I'm doing my clinical evaluation, I'm doing my phenomenological, what hurts, where it hurts, what's going on. If they have if nothing in their current life is obviously causing them distress, they don't have marital dysfunction, they're not suffering from any medical illnesses, and there's no major stressor in their life, and yet they have some suffering phenomenologically they're carrying around with. I'm depressed. I'm anxious, generalized anxiety, dysthymia, these kind of things that have no sort of connection to to current or even remote life events. The rule of thumb is if it's not about what's going on in their current life, it's probably something from the past that they're carrying around with them. And then we get into is is what they're carrying around from the past, is it stored in their linguistic um, faculties in their brain? Like, can they talk about it? Can they say, well, I'm afraid. I was working with a patient recently who said, I'm afraid of men. And when I'm around men, I freeze. And it's really hard for me in business because males make me freeze. But she was able to say, and I understand when I asked her about what she thinks the origins of that are, she said, well, I remember when I was really young, my dad screamed at my mother all the time. And I remember that. So that's the narrative memory that she's able to link back to. Now, if she were to say, I have no idea why I'm afraid of men, then this is a process that we were kind of trying to put the pieces of the puzzle together in what is going on in the other person's mind. So they have a memory network that when I say they, I'm talking about patients, a lot of patients, but especially when we're focusing on the patients with pre-verbal trauma that happened to someone before they were able to store it linguistically. We're trying to identify what those fragments are and then start to try to put them together in some coherent way. So usually when we think about the neurobiology of pre-verbal trauma, and there's a lot of good work out there from people like Stephen Porges, who does polyvagal theory, and others about that the kind of trauma, the kind of pain and suffering that people with preverbal trauma carry is not at the cortical level of our brain. It's really kind of more at the at the deep at the brainstem. So the kind of often talk therapy is not going to be helpful with patients like that because they can't mentalize what happened to them. They don't know. They don't have a narrative linguistic memory of, yes, when I was 6 months old, my mother was schizophrenic and she left me in the crib for sometimes hours with a dirty diaper and didn't feed me. So that would be held not as a memory like we're talking about, but we held as a state memory. How do you get to that? That's what we want to talk about. So if it's not the present, is the current state due to something that's in one's current life? If you kind of rule that out, and there's often their symptoms are clusters of symptoms, not a specific disorder. So these patients also show multiple pathologies, and they're all jumbled together oftentimes. So what we're talking about again is implicit versus explicit memory. So explicit memory is narrative memory. Implicit memory is what we remember, but we don't remember with language. So I remember So an implicit memory is if Louis, you come into my office. I come into your office and I sit down and I freeze right away. You can see I'm going into a freeze response. And you would ask me, what would you ask me?
I guess I might ask you a little about what's going on for you. What are you aware of in your
Yeah,
experience? Yeah.
yeah. I don't know. I don't know. And I think what so yeah. So you're trying to help the person unpack it,
Hmm.
but that freeze response can be so deep that it shuts down any ability to actually reflect upon even basic bodily states and sensations. So you've already picked up data as you begin because you're observing, right? You're vigilantly observing the client's or patient's presentation. Like you're noticing it freeze. You don't know why, what's going on. Hopefully you'll eventually get to that, but it's not stored, it's maybe not stored linguistically.
Hmm.
Does that make sense?
Yeah, for sure.
So the other concept I want to introduce is when we're working with patients with preverbal trauma, we're basically talking, I think, about attachment experiences. So that how do we even get to that? So this this illustration is one that I think shows that if we think about the self system as having a foundation, and the foundation is in attachments. And we know a lot about attachment theory, different kinds of attachments. We're all pretty well versed in that as clinicians. But a person can have a crumbly attachment system and sometimes even a pretty solid structure, and which can be very misleading. So they seem to function pretty well most of the time. But when we get them into our offices, our hospitals, something in their life, there might be some kind of allostatic load, which is the load, the overall stress that's put on any system. That allostatic load is going to have a diathesis or a point where the stress, the fault line is going to occur. If the allostatic load is too much and the early attachments are insecure or disorganized, the fault line could be in the attachment system. And that can look, um, and patients in that zone are in survival. So they um, often look pretty disturbed because their attachment structure has been undermined.
Jeff, any case examples come to mind for that sort of a situation where someone is
Yes, yeah,
how to
yeah.
discern someone is looking
Yes,
functional?
so yes, yeah, that's a great question. So in one case, a um, highly educated professional who was in a practice was um, having marital difficulties and beginning to go through a divorce. And the early attachment stuff and unprocessed trauma from very early on made his structure just fall, and then had to be multiple hospitalizations during this because it kept looking like he was doing well, and he would do well for a while. He would be practicing, he'd be relating, and then the whole thing would collapse, and he'd have to go to the hospital. And to put like so, it was the basic foundational part of his self system was what was crumbly. So when the winds of life, the allostatic load comes on us or our patients, you can kind of see if you do a careful history and or you interview other people in the system, how they were functioning, what their premorbid level of functioning was, what might the stressors be, and how severely did they, let's say, decompensate.
Thank you.
So the other important concept that I think we should all familiarize ourselves with when trying to conceptualize and work with patients who are suffering from preverbal trauma is the concept of state memory. And so we could do a whole masterclass on state memory. Maybe we will at one point if we have an interest in this. But so state memories are basically undifferentiated affects, sensations, and somatic experiences. And typically they are experienced preverbally. So an example of that is often you're working with someone now who, when we start to kind of like figure out what's going on, how you're feeling right now, what's going on, we'll say, I'm totally empty inside. There's nothing at all inside, but there's some distress. There's some distress. I feel um, sometimes they don't even say anxious. Sometimes they don't even have that. It's more like there's some sort of pain and this emptiness. And when you start to unpack and a lot of patients with preverbal trauma talk about emptiness. I think it's kind of a marker often for me of preverbal trauma. I'm empty. There's nothing in there. It's not actually that they're empty. It's the way that I phrase it. We can talk more about that when we talk about treatment. Is there's a part of you inside that is carrying something, and that we have to understand what that is. So that's the undifferentiated affects. They can't say, I'm really angry at my mother because when I was 2, she used to go out drinking with her girlfriends and left me home for a couple hours alone. And I was in extreme distress, and there was no one there to co-regulate me. So that's another important kind of concept that we think about as therapists. A big part of what we do is we're trying, we mostly are dealing with people who are underregulated or overregulated, and we're trying to help them come into a sense of better self-regulation through co-regulation. And before we started, when we were talking, you were calling up, I think, one of the nurses on your staff about helping a patient who was severely dysregulated get re-regulated with some medication. So psychotropic medication for some people is a form of co-regulation. And David Mintz, when we interviewed him, talks about how important that relationship is in administering those medications, because that's a whole nother fascinating area. And if you're interested in that, watch the Eminent Psychotherapist that we did with David Mintz, because it was really brilliant. I don't know if you got to see it or not, but it's about not just the psychoactive property of the medication, but how the healer delivers it.
Yeah, we've had a lot of interaction. He's great, and it's a very interesting topic of discussion for sure.
Yes. And what I noticed, because I overheard the call, is you were helping, I think it was a nurse that you're talking to. I think you were helping your nurse stay regulated and dealing with a sounds like a decompensating patient, or the patient that really needed to be uh, stabilized. So
Mhm.
the relational aspect of it all is critical. And whether you're a nurse practitioner and you're primarily doing psychopharm, it's still really important to understand these concepts, especially working with like I know a lot of the people you work with are SMI and comorbid patients. So they're challenging.
Yeah, for sure. I mean, there's a question in the chat. I'll just say a quick comment related to that, that this is definitely an area of interest of mine. I just finished my internal family systems level 1 training, and
Excellent.
there was another MD in that group who led a led a little breakout session talking about parts and medications, and we had a very robust discussion, and a lot of led to a lot of areas that I'm interested to inquire about, and being familiar with David Mintz, who's already doing this type of work, and wondering what parts of our psyche show up to our therapy sessions, what parts of our psyche show up to our medication sessions, looking for different things, and certainly regulation and soothing through various ways. So very interesting. And we have a question from Ken, or a comment and a question. Rocking in bed might be considered a silent scream. What do you think about that?
Exactly. I think that's a wonderful observation. Yeah, I think that is and an attempt at self-soothing. And if that self-stim is one's attempt at providing themselves with soothing. And I'd be really interested in understanding that with the person. Like, did anyone ever hold you and rock you? Did you have a rocking chair? Um, I still have it up in our bedroom. I still have the rocking chair that my mother rocked me in when I was a baby. So I mean, it's really powerful stuff. That's a great observation. So what we're trying to do in all the work that we do, I think, is attunement, trying to find the signal. There's so much noise in the system, right? When we get people coming in, they have all these different symptoms and all these different issues, and as the clinician, we're really trying to find the signal in all that noise. What are they trying to communicate to us? Let's say, because I think IFS is great, what are the different parts of oneself trying to communicate? And can you listen with that third ear? I was with a young person today who was flipping into different parts of himself, which he was not aware of at all. And and it was so obvious because he would start to say things like, you're a total failure, you're totally stupid, you messed up and it's like you could hear his whole voice, demeanor. Not that he's a multiple personality, but if you pay attention, we all have these different parts. And for people who have endured trauma, their parts are way more fragmented and more discrete often. And to an extreme, they're dissociative disorders, but identity disorders, but the part stuff is so interesting. So trying to find the signal, tuning into what are the different parts communicating? I don't believe that anybody can help me. I failed at every treatment I've ever had. You're not going to be able to help me. I'm a loser. I'm a failure. So trying to get that signal. And how do we do that? And I think we go into this field for the most part, I think because we have this tremendous interest in trying to help people who are suffering. And also, I think many of us that go into this field have a particular, whether it's our family, whatever it is, that we have this way of attuning that hopefully we refine and improve on over the years. That, like, how do you know in all that stuff that you get, Louis, when your patient sits down with you and you have X number of minutes to try to figure out even what to give them for medication? How do you even, like, where does your signal, where do you start to pick up that signal from, and what does that all mean? So part of this work, and this is for all clinical work, whether you're like we've been watching the pit about what goes on in emergency rooms. This phenomenon is important for all practitioners, emergency room people, APRNs, psychotherapists. It's about this idea that we're trying to bring someone into our entrainment. And this slide, I think, is interesting because when I present with my daughter Elizabeth, she says that um, my daughter is all knit, and she said, this is like what we do when we're knitting. There's a tangled up ball of yarn, which is in the other person's mind. And as a therapist, we are trying to pull the strings out and untangle that and start to reorient, label, sort, differentiate with them, which is mentalization, which we can briefly talk about. So, what are some other ways of getting at preverbal trauma or any
Actually,
trauma?
could you
Obviously,
could you say a word about, might be a good time to say a little bit about mentalization and kind of what you're meaning really. I think that's a great metaphor of the yarn, and it might be a good time to
yeah.
just
So mentalization is a concept that was developed by Peter Fonagy and his team, which is it's a new word. It's a great word, but there are lots of different words throughout our development of psychotherapeutics over the 20th century that kind of say the same thing. So it's about um, um, close process monitoring. It's about picking up on what you're experiencing sitting with the patient in the room, whether it's when that person came in to your office and they were already in a freeze response, picking up on that, and then you pulling that string like at their pace, like, I noticed that you came in, you sat down and it looked like you wanted to like a freeze response. How are you feeling about coming here today? Anxious. Well, okay, so tell me a little bit about that. What's that anxiety like? Well, and then as you're untangling this, so mentalization is uh, uh, tuning to the sensations, the somatic experiences, muscle tension that people have, and then starting to label it like, and that's where psychoeducation comes in. So mentalization is really about helping people with emotional intelligence. And Goleman's book, I think, is great in terms of what are the components of helping people learn how to understand what their sensation, they pay attention to their sensations, and then to begin to tune into them, follow them, and see where they lead, be curious about them, and then begin to label them and put them into a narrative um, package. And that's what mentalization is.
thank you.
Does that,
Yeah, and you referenced a book by Goldman. Is that specific?
yeah, emotional intelligence. It's a great primer on, and I used to often suggest to patients to read it because he gets at he gets at the components of emotional intelligence in a very, I think, elegant and concise way. But the what we do as healers is we're attuning to people in a way that they're not going to get anywhere else, because it's not just reflecting back what someone's saying to you, it's staying open to the entire experience of being in a room with someone. And most of the communication, I believe, is not the content of what they're saying to us. It's the nonverbal communications that they're making. Do they come in and they sit by the door? Like, are they like, I'm gonna sit in this chair by the door here. Okay, that's interesting. You want your back covered, right? Yeah. And I was working with a patient last week who um, we were just talking about some different things, and he was talking about that he was losing his hair when he was young, in his teenage years. And as he was telling me about that, he went like this, and I said, "Oh, that's interesting. You just looked like you went into this really protective response." And I said, "Just," and he's a very verbal guy, so he was saying in a very at a very verbal level, like, "Yeah, yeah, I know. I noticed I did that." And so, okay, just lean into that. Just let's take a minute, see, what. And as he sat with that, he said, "I feel like there's someone coming up behind me." And then he started to have a de-repression of experiences he had when he was in school, where people would make fun of him because of his balding, and so you're using that attunement, not just listening to the words. They're important, but what's going on when they're sitting in the room with you is really what's important. So what are the triggers? Like what, and this goes for anybody we're working with. Get a list of what the triggers are, because sometimes patients know what their triggers are. More than not, they do not know what their triggers are. They can get stuck in states that have triggers that are so subtle they're not even aware of. For example, coming into an office can be in and of itself can be a trigger for people who have been abused, right? Just intimacy, that kind of intimacy can be a trigger. So if they have an idea of what the triggers are, that's good. So in terms of the pre-verbal trauma, what you're going to often get is people are going to come in and they're going to be in some kind of state of dysphoria. Like they might say, I'm just not feeling, I'm feeling crappy today. I'm not feeling right. And I'm exhausted. I don't have any energy. So it's not differentiated emotion. Like, yeah, I'm really pissed. My son yesterday came home from school and he blah 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 blah, and I'm just really pissed. So that's a whole different kind of way that we're working than if someone comes in and they're like, yeah, I got a pain in my shoulder. I got a pain on my side. I hurt. Um, and we can get really distracted by that stuff. Okay, let's send you to the orthopedic guy and see what that pain's about. That might be appropriate, but it might be useful at first. Just pay attention to like what you notice in your shoulder right now. Let's and as you show curiosity to the people we're working with, and they start to feel more curious, you're going to mine a lot of data, a lot of important data.
Jeff, question relating to this that I've noticed maybe in the last decade, maybe 2 decades, there's a larger there seems to be an upswell in something that's now called more formally like somatic psychotherapy, and I wonder how connected to whatever practices is not something I'm hugely familiar with, but sounds like this is related to what you're talking about, the sort of direct awareness of the
Yes,
psychic element of
yeah,
things, and as a therapist, but also helping the patient themselves to attune to that. So just wondering your thoughts on that.
that's a really, really good point and question. I think that it's imperative for us to get some training in somatic therapy. Now, I find there's a wide range of quality to this kind of training, but basically, I think what we're learning now is that for people with the kind of trauma that we're talking about, especially pre-verbal trauma, top-down therapy, talk therapy, is not going to get at it. So you don't necessarily have to go through a whole training program. I did a week with one of the preeminent somatic therapists years ago, and it was very helpful. But what I think is important, and you don't need to necessarily go through somatic therapy training to be able to use this way of understanding. It really is about attunement. Like what is going on in your whatever. I got a guy I had yesterday who came in, a young guy who feels like he's got sensations in his legs. He says, I got and he's getting nerve conduction tests. He's getting had an MRI. So the medical people are all trying to find out what, and it's like, what's like what, just what's going on in your legs right now? And this young guy's got some severe identity issues that he's suffering from. And I think his legs are a conduit of a lot of unprocessed feelings he has. And so with this, with the somatic um, channel, it's about that attunement and paying attention to that, not just looking for the words, and also being willing to sit with people sometimes quietly and just let's take a minute. Now, a lot of times I'll start a session out with now with just saying, before we get started today, why don't we both just take a minute and just kind of just turn inward and just see what we notice. It's like a centering. Like I find that can be really helpful, especially for these really highly anxious and dysphoric patients in a lot of pain, a lot of emotional pain that is not um, they're not able to really get at the root of or talk about or resolve with typical, kinds of therapy, conflict resolution or whatever kind of therapy. It's really helpful. So I would learn as much as you can about it. I think with these patients, it's the most important part of therapy. Moving from the somatic experience, then it becomes easy to start the labeling. You're psychoeducating. One way to understand this for people who haven't seen the still face experiment, Ed Tronick's still face experiment, is watch the still face video. It's about 5 minutes, I think, and I've probably watched it a couple hundred times, and every time I watch it, I find something else in it. But for those of you who don't know about it, basically it's an experimentally induced attachment trauma. He's asking a mother with a secure attachment to go blank, and immediately, I think it's a 12-month-old infant, starts to try to reorient the maternal figure by cooing and then after a couple of minutes goes into extreme distress. So if you want to kind of get a visceral experience of what preverbal trauma can be like in terms of those state memories, look at the still face video and then imagine that in the video the mother comes back and re-regulates and the kid's fine in like a minute, back to regulation. Imagine what would happen, and I know you've seen this video, Louis. Imagine what would happen if that kid was chronically stuck in that state. What's
Yeah.
going to happen is you're going to pass sympathetic nervous system arousal and go to dorsal vagal shutdown. So a lot of the patients that we get um, with these extreme shutdowns where they cannot function. If you think about the polyvagal theory and Stephen Porges, that dorsal vagal shutdown is the brainstem. It's the reptilian brain just hiding under a rock. I have someone right now I have a couple people right now who will go to bed for days, not get out of bed because they can't get themselves out of bed when they go into that dorsal vagal shutdown. So a lot of that we have to do retrain their brain states, which is a whole nother master therapist class that we'll do another time on how to use technology to get at those basic brain states.
And Jeff, there's another
So here's
comment in the chat related to the rocking in bed. Someone writes that related to the rocking in bed, the child seeks witnessing. Later in life, relationships are ended because of a sense that they are not good enough. The protector of horrific shame eventually grows tired and perhaps is seeking IFS's sense of self to compassionately witness. They agree it goes back to preverbal trauma. Enough life experiences can reveal a narrative. So just
well well stated. Yes. So here's something that one of my patients said to me this week. I suffered from chronic fatigue throughout my life. There is a big hole that you didn't get what you need from your mother. So so now this is mentalization, right? She, we've done enough work at this point where now she is able to mentalize it, and her mother's still alive, so she now has data too to help with that narrative. This emptiness that I have inside it's not because something's wrong with me. I'm not defective. It's really because I was neglected and emotionally abandoned. So here are the core themes. So it's lack of attachment, neglect, and abuse early on, right? So before the person has language. Now, these things also are uh, kinds of trauma that people suffer at any point in life, but if they're suffered pre-verbally, they're maintained in these somatic states that we're talking about, state memories or somatic states or a combination. So it's the memory system. It hasn't consolidated, so it can't even, it's not fragmented. Like when we work with people later and they have trauma, their memory network can fragment. So they have different elements of their neural networks hold different parts of the trauma. It could be a smell, could be a state memory. But with these patients, the memory system never fragmented because it wasn't developed enough to fragment. So it's really tough to get at that and then to put that into some narrative framework, which they can do the grief work and working through the anger, the guilt and shame that comes along with that. So here's what we were talking about before. And this was an example, Louis, of another woman I had last week who, when I've been doing EMDR with her, I don't know how many of you are trained in EMDR, but I do a lot of EMDR with all different kinds of patients, but it can be very helpful certainly with the preverbal trauma patients. We can actually process the state and see where that takes you, because often they'll start having fragments that start to come together in a narrative. But this patient, literally, this is a very high function patient, and she's got that crumbly foundation thing. So when she's in the office with me, sometimes we'll be sitting there or talking, and she'll go like that. It's like an electrical current has. It looked like she's being defibrillated. Honestly, it's like that intense. And then she goes. Then she can go into like this. And so using this and these markers and other data points, she's been able to put together that when she was very young, before she had language, she has a flash memory of her dad was violent toward her mom, a lot of screaming, and she has one flash memory of being crouched in the corner in the kitchen like this. And so, and then later she told me, my father told me he would roll up a diaper and hit me. Roll up a newspaper and hit me in my diaper. He would brag about it. He was a very disturbed fellow. So these are trace memories that we're following. And you might say, well, how do they remember any of this? Memory is fluid, and what we're doing is we're co-constructing a narrative that can be used to process the unprocessed affects and to recode the operating system with a more positive belief system. So we talked a little bit about the process of healing. So this work requires a building of a narrative. You can do that in lots of different ways. You don't obviously we can't go back, although sometimes people have videos of early stuff or pictures, which can be very helpful. So sometimes I'll ask them to bring videos or pictures in. One guy that I'm working with right now came in to see me and had 50 videos, brief videos of him crying and talking about how terrible he feels. And so the way that I dealt with that, the way I'm dealing with that is I said, and he's presented to all of his providers these videos, and he wants them. I said, this is a part of you that is doing its best to communicate something. Now, this guy had I think a fair amount of early trauma, maybe preverbal trauma, I'm not sure, but certainly attachment trauma early on. he was terrified of his father. He still holds that as a body memory. But the videos of him that he shows me of him just crying and saying, I don't do. It's just like a 2-year-old. So these are um, kind of trace memories that you can use to start to put together a narrative that the person then can use to formulate their story. And as I think the person was talking about, and have someone bear witness to it. Yes, it was really bad, and you're not defective and you're not unlovable. You were really mistreated, and you've internalized a lot, and you carry around this as state memories. And I will psychoeducate about state memories. What I think we're talking about right now is this is a state memory. This is not coming from your current life. This got triggered by the fact that your husband got mad at you last night, but it's not about this state memory. Like you've been stuck in this for 3 days now since he said, you didn't that you cooked the steak too much or whatever. And then we get into some of the different approaches like the IFS stuff, that reparenting those parts. And they're we don't have time to get into those today, but the IFS, I think, and EMDR offer a lot of very helpful um, techniques and strategies for then once you identify that part, how do you reparent that part and reblend that part and bring that part back to self? So to summarize, here are the steps. So of working with preverbal trauma, locating the source in developmental time. A developmental history is essential. I try to get that from all the patients I work with, where a timeline, where were the major events in their life, positive and negative. And then we talked about inviting mentalization, which is basically like being really curious about what's going on with other people. We wouldn't be in this field unless we were really curious, right? Like we're just curious people as practitioners. We want to figure out what does this mean? What's going on? And then when we demonstrate that, then that invites the person, yeah, I wonder why there's this part of myself saying all these really toxic things to myself in such an angry way. What's that about? Where does that come from? So you're inviting mentalization and a lot of psychoeducation. You're using our psychological um, mindedness to help them develop psychological mindedness. This is what my colleague and friend John Santapietro calls exercising in the psychological gym. You're exercising these psychological processes that had atrophied because they were never had any attachment figure along the way or limited to help them co-regulate, learn how to, like, you look really sad right now, what's going on? Just basic stuff that most of us get that they maybe never got. And then identifying the markers, like some of the markers that we talked about tonight, like patients going into different body states or going limp or going sympathetically like defensive, like they're ready to assault you. And then co-constructing that narrative. And this takes some time. This is not like short-term therapy. This is something that occurs over the course of time in the context of a trusting and safe relationship. And then processing the emotions as his narrative comes up, like, yeah, wow, that was really that must have been really horrible when you were just sitting in the corner there, terrified that they were going to kill one another and not even having the language to talk to anybody about it. And then exploring strategies and seeing what works. So we can stop here and discuss and take questions. Any questions coming through?
I'm seeing no more questions so far.
Okay, anybody, if you have questions, comments, please jump in. And I think we can unmute people if they want to talk at this point. But we will have a recorded version of this up for your colleagues in the next week or so. So people who haven't been able to attend will be able to watch it. Okay, we got some. Can you do the hand raising? Can you see it from? Can you get the questions, Louis?
I cannot. I don't think I can see the hand raising, Jeff. So that's and you could, if you wanted to, stop sharing your screen at this point, I think.
Oh,
there we go.
Okay. Thank you. So let's see. So anonymous attendee, preverbal trauma creates a powerful protector in the guise of a judge that act to protect against shame at all costs. Yes, very true.
And a thank you that I'll share with Jeff for your presentation. Very empathetic.
Okay, thank you for watching, and come back again. And if you have topics that you want us to do a master class on, please email me at
Denise is trying to raise her hand. I don't know if you're able to call on Denise.
Okay, let me see. I think I can raise your hand.
It may be in the Q&A that you, maybe there's this thing that says answer live. I'm not familiar with this. Yeah, I don't have that functionality. So if you see Denise, then you can probably unmute her. And Denise, if we can't figure it out, we're sorry.
Sorry, Denise. I don't see chat. Sorry, Denise. I can't figure out how to.
If you can type something, Denise, then we may be able to answer it that way. Otherwise,
Yeah, sorry, I can't. We'll figure out how to do the unmuting in our future ones, because we don't really do that when we do the regular eminent psychotherapist. But for this one, we're going to be having time to
here,
discuss.
Denise, yes, Denise, what about music therapy?
Oh, excellent question. Excellent question. Music therapy is a excellent way to reset the brainstem and the limbic system. In fact, for those of you who might be interested, we're doing my daughter and I are going to be doing a weekend at the Kripalu Center in September, where we're going to talk about all these other ways for us as therapists to reset, and then we can use that for our patients as well. So if you get a chance, check out the Kripalu Center. The title of it's Nourishing the Self of the Therapist. We're going to be there for a weekend, and it should be pretty enjoyable and informative. Any other questions?
I don't see any in the chat.
All right. Well, thank you all for attending. And Louis, thank you so much for being our host and our learning guide tonight. I hope that you'll be willing to come back and do more of these with us, because you
My
have
pleasure.
Experience and good questions.
You're very welcome. And Janice just put a thing in the chat about students and professionals should know 65% of resistant depression is due to early trauma.
Yes. Thanks, Denise. That's excellent and true. All right, folks, have a great night, and let your colleagues know about that. This will be available, the recorded version next week, or maybe even this weekend. Thank you all for attending, and continue to do your good work. Bye now. Okay, and